Hello, everyone. Now I'm going to be speaking about differential diagnosis of red eye. And before I start, I'd like to point out that you can reach me from my emails, which are visible in the first and the last slide, to ask me anything about the red eye and ophthalmology in general. So we start by telling that red eye is not a diagnosis, but a symptom. And this symptom is important because we need to know when to refer the patient to a ophthalmologist. And to do that, we need to differentiate between these diseases that may cause red eye. But only memorizing these diseases and reciting them one by one is not making a differential diagnosis on red eye. To do a differential diagnosis, we need to have an idea on each disease separately and then trying to make a definitive diagnosis to the patient that comes with red eye. To do that, we have some important findings to consider, and we're going to be looking at these one by one. Just for the context of this lesson, I'd like to point out that additional pathology means, for this lesson, any other pathology other than red eye is included in this additional pathology part. Let's have a look at discharge. The discharge can be from serous to purulent. The serous discharge, along with a mucous part, may be caused by viral infections or some allergic reactions. But as you all know, purulent discharge that comes with pus is usually associated with bacterial infections. The reactions, the inflammatory reactions of the ocular surface can be seen on the palpebral conjunctiva. The upper palpebral conjunctiva is seen in these pictures, and on the lower right-hand corner, you can see the lower palpebral conjunctiva. The one on the upper right-hand corner of the slide is showing a papillary reaction. This papillary reaction may be caused by foreign bodies, bacterial conjunctivitis, bacterial infections, and some allergic reactions. The most common foreign body, you should know, is that contact lens. So every contact lens wearer may have a papillary reaction to some degree. The one on the lower right-hand corner side, you can see some follicular reactions, which is caused by viral infections, usually. But some bacterial infections may mimic viral infections because the microorganisms that cause that bacterial infection is actually intracellular, such as chlamydia. We also need to consider visual acuity because visual acuity decrease may help us differentiate between these diseases. An opacity on the cornea is no doubtly going to cause a decrease in visual acuity. But what about some tear film changes? For that, we need to have a better understanding of the corneal structure. So the cornea is like a glass. The glass on the left-hand side has a smooth surface, so it's very transparent. The glass on the right-hand side has a rough surface, so it's not transparent. It's like a ground glass, and it just changes the light path so that we can't see behind it. So the cornea should have a smooth surface. But when we look at the corneal structure, we can see that there's a stratified epithelium on top of the cornea, and the surface of this epithelium should be smooth. But counterintuitively, when we look at the transmission electron microscopic views, the surface of the cornea has a lot of microvilli, which causes a roughness on the surface. This is because the cornea does not have any vasculature and it needs oxygen to increase the diffusion surface of the cornea. But the problem is with this rough surface, cornea should be like a ground glass and should not be transparent. However, this transparency is created by the tear film. The tear film covers the microvilli and creates a smooth surface so that we can see clearly with a transparent cornea. This slide is actually important because not only the opacities on the cornea can cause a decrease in visual acuity, but also the disruption of corneal tear film may cause a decrease in visual acuity. Now let's have a look at our first entity. The first entity that we're going to talk about is subconjunctival hemorrhage. These patients comes with symptoms. The only symptom these patients have is the red eye itself. The visual acuity is not decreased. There is no pain or discomfort. There is no discharge, no inflammatory reaction in the conjunctiva, and there are no additional pathologies. The important part here is most of these patients are idiopathic, so they don't have any treatment options. You don't give them any topical medications or oral medications to treat. So you need to know that if this patient has an idiopathic subconjunctival hemorrhage or not. If there is an underlying etiological disease, you need to figure that out. And that may be hypertension, Valsalva maneuver, some medications that may cause anticoagulation, and some blood disorders. So you need to rule these diseases out and then diagnose this patient with idiopathic subconjunctival hemorrhage, and then tell the patient that it's gonna go away within 2 to 3 weeks. This is a good example of a complicated patient that you need to understand that not all patients have only one disease. They may have some concomitant diseases, as in this patient. This patient came in for the red eye, but this patient also has an exotropia. But we're going to treat and we're going to focus on only the patient's symptom. What is disturbing this patient? So the exotropia, we know that for this patient is for a long time, so we don't need to talk about that. So every patient should be assessed according to their symptoms. And this patient this patient's symptom is only the subconjunctival hemorrhage, so we're going to focus on that for this patient. And this disease, like many others, have a spectrum. And the spectrum here is, you can see that from very mild to very severe. And probably this severe subconjunctival hemorrhage is caused by an anticoagulant use. The next entity that we're going to talk about is conjunctivitis. Conjunctivitis is the infection or the inflammation of the conjunctiva. And if we focus on the bacterial conjunctivitis and look at the important findings here, the visual acuity usually fluctuates because there is a disruption of the tear film and there is a hyperlacrimation because of the burning sensation. There isn't a real pain, but there is a burning sensation here. And the reaction here is papillary reaction, and there are no additional ocular pathologies. So we can figure this out as bacterial conjunctivitis. If there were follicular conjunctivitis along with a serous secretion, we would just tell that this patient had a viral conjunctivitis. This is an example of a viral conjunctivitis with follicular reaction in the lower eyelid and bilateral disease. And this patient has another viral conjunctivitis, but this is important not only because this is contagious, but this viral infection is caused by adenovirus. And adenoviral conjunctivitis is important because it may cause some corneal opacities, so the patient's visual acuity is decreased, and if not treated accordingly, it may be permanent. Another entity that we're going to talk about on the subject of red eye is dry eye disease. Dry eye disease is a very complicated disease, but it is associated with inflammation of the ocular surface. And it may be because of the reduced aqueous production, so the reduced tear film, or an evaporation in the tear film because the lipid layer is disrupted. So we know that the lipid layer is produced by meibomian glands, and if there is a disease of meibomian glands, the lipid layer will not be there anymore, so that the tear film will evaporate easier than before, and because of the inflammation there will be red eye, and because of the tear evaporation, the visual acuity will be disturbed. Here you can see that the white dots, and these white dots are the orifices of the meibomian gland. The meibomian gland is important for the lipid layer of the tear film, and in this case, the meibomian gland dysfunction causes the lipid to be dysfunctional as well. So here is a toothpaste-like lipid layer capping the meibomian gland orifice, making it not work properly. And there are some crusting on the eyelashes, which indicates eyelid disease. This is a very severe form of eyelid disease, which is called acne rosacea with telangiectatic vessels. And you can see that because of the inflammation, the corneal surface has become inflamed, and there are some neovascularization and opacities on the cornea. So dry eye disease may cause a permanent decrease in visual acuity. The meibomian gland inflammation, if acute, is called hordeolum, and may trigger a chronic version of it, which is called chalasia. And chalasia is important because you need to treat it with surgical procedures to clean this abscess out. There are some other dry eye types. This is called an exposure keratopathy. This exposure is caused by thyroid ophthalmopathy, which causes the exophthalmia. Because of the exophthalmia, the eyelids do not close well enough to make the tear film on top of the cornea and lubricate the cornea well enough. So because of that less lubrication, the epithelium just sloughs off and makes it possible for the microorganisms to grow there. In this case, it caused a keratitis. You can see the opacity here, and the opacity on the cornea, along with some purulent discharge you can see here, is indicative of bacterial keratitis. And the only option that you have here is trying to close the eyelids by a surgical procedure to reduce the exophthalmos. Any eyelid abnormalities can cause dry eye. In this case, you can see the lower eyelids have a problem, and there is an exposure in the cornea itself. The eyelids cannot close well enough. And because of that exposure, the cornea has become opaque as well. The next entity is a combined entity, which is called episcleritis and scleritis, the inflammation of the sclera and adjacent tissues. So we're going to look at these together because scleritis is some sort of a severe form of episcleritis. Episcleritis is more superficial. It's usually idiopathic. It may be idiopathic, and the pain is really mild. In scleritis, the pain may wake the patient at night, and scleritis usually needs more immunosuppression than episcleritis. These patients usually do not have a decreased visual acuity, but they have pain. They don't have any discharge. There is no reaction, and there are no additional ocular pathologies if it's not too severe. Here you can see an additional pathology. In this case, this is associated with rheumatoid arthritis, and this is called a necrotizing scleritis. Because of the necrosis of the sclera has melted down, and you can see the choroidal vessels in violet color right underneath the conjunctiva. Here's another entity that can cause red eye, it's called keratitis, the infection or the inflammation of the cornea itself. And here, the blue light, you can see that we have dropped fluorescein stain on the ocular surface, and we're just looking at it with blue light. It just makes the fluorescein, which is actually orange in color, fluorescence green. It means that in this part of the cornea, the epithelium is not intact. And this part is the keratitis itself. If it's like a dendritic shape, it means that it is probably caused by an herpes infection. Here you can see purulent secretion, the discharge. There is an opacity in the center of the cornea. There is a severe conjunctival hyperemia, and this is a typical bacterial keratitis. As you may well be aware of, that this patient doesn't see well, so visual acuity decreases significantly, and this patient usually has pain and burning, and the discharge is purulent because it's bacterial, but it may as well be mucus or serous, depending on the etiological microorganism. And the additional pathology here is the opacity on the cornea, which indicates that this patient has a keratitis. Here we see another patient with red eye. The important findings in this patient are like this. The visual acuity is not decreased. The patient is hyperlacrimating. So there is no discharge, but there is tearing in the eye. There are no reactions because it's acute. And there is an additional ocular pathology that you can see here at the 6 o'clock of the cornea. There is a metallic discoloration, which indicates that this patient had a metallic foreign body on the cornea. If you don't remove this, you will never be able to treat this disease. And here is the metallic foreign body in another patient. And here is a forceps that would try to remove this foreign body from on top of the cornea. Here's another patient with red eye, and by looking at it with a light microscope, we cannot see what's wrong with this patient. But the patient has hyperlacrimation, severe pain, and photophobia, the fear from light or sensation of pain from only looking at a light source. And again, it's very acute, so there are no reactions, but if there were, it would be papillary reactions. And there are no additional ocular pathologies by the look of a bare eye. So we need to find something else. So how about we put some staining, like fluorescein, and check the ocular surface with a blue light. Then we'll see the additional pathology. The additional pathology is corneal abrasion. So the corneal epithelial layer is sloughed off by something. So this pattern is very pathognomical. So it has vertical stripes, which indicates that there was a foreign body in the upper eyelid, and with every eyelid closure, it just removed a part of the epithelium. So what about the lines, horizontal lines? So it means that the patient just rubbed her eyes. So that is called an iatrogenic trauma. So we need to find the foreign body in the upper eyelid, but usually you don't find it because during the rubbing or the hyperlacrimation, the foreign body usually goes away. Okay, now let's have a look at another entity which may cause red eye. The glaucoma causes red eye, but only one subtype of glaucoma causes red eye, and it is acute angle closure glaucoma. It causes decreased visual acuity because it causes corneal edema, and there is no discharge, but there is hyperlacrimation because of pain. There is no reaction. and there are many additional ocular pathologies. One of the main ocular pathology here is that the pupillary reaction is diminished. There is no pupillary reaction, and the pupil is somewhat midriatic. And the angle is closed, which means that normal angle is open, so that the aqueous humor is produced in the ciliary body and goes to the anterior chamber through the pupillary area and leaves the eye through the trabecular meshwork. So this part is the angle, which means that it's iridocorneal angle, the angle between iris and cornea. But in acute angle closure glaucoma, the iris comes into close contact with cornea so that there is no trabecular meshwork for the aqueous humor to leave the eye, which increases the intraocular pressure enormously so that the patient has real pain, and it may even cause nausea and vomiting. So how can we see if the angle is narrow or closed or normal? So for that, we need an additional device. It's called a biomicroscope that we use. And this biomicroscope is called a slit lamp biomicroscope because it can produce a slit of a light. So why is the slit lamp biomicroscope important? Let's have a look at this picture. This is a picture taken from a biomicroscope with a broad beam light. So this is the reflection of the light, and it's a broad beam light. So I cannot see if the arrow on this picture is pointing to the cornea or anterior chamber or lens. And for that matter of fact, if this opacity is on the cornea or on the lens, so we cannot differentiate that. But if it was a slit lamp, here the slit light is produced from the left side of the patient in a 45 degrees angle. So now we can have a anatomical finding of all these structures. The first place that the light comes into contact is the surface of the cornea. And here is, you can see the corneal stroma, the back of the cornea, the anterior chamber. This is again the reflection of the light. And right after the anterior chamber, you can see this curve depicts the anterior part of the lens, the cortex of the lens, and here the whitening of this part is the nuclear sclerosis. So this patient has a nuclear cataract. And all this is possible because we can produce a slit-like lamp, light to the cornea. Let's have a look at this picture on the lower right-hand side, and you can see that again, it's a 45-degree light coming from the left of the picture. The first one, corneal, superficial cornea, corneal stroma, back of the cornea, some anterior chamber depth, and the reflection from the iris. So there is some space between iris and cornea. And what about this one? This one is actually important because this patient does have an angle closure glaucoma. Let's have a look at it. The slit is produced from the left with a 45-degree angle. The first part is corneal, superficial cornea, the stroma, and I don't see any aqueous humor and any anterior chamber reflectance here. The only reflection is coming from the iris. So the iris is fully in contact with the cornea. Thus, this is an angle closure glaucoma. The next disease entity is a uveitis. Uveitis is the inflammation of the eye, but the focus here is to the inflammation of the anterior part of the eye, which is usually iris and ciliary body. So if it's an iridocyclitis, the inflammation of iris and ciliary body, it may cause red eye. Other than that, the posterior uveitis does not usually cause red eye. In this case, the visual acuity is usually diminished, and there is pain, there is no discharge, no reaction, and there are some additional pathologies which we're going to see right now. Since the inflammation is of ciliary bodies, the redness is in a circular type, which is called ciliary flush or ciliary injection. Because there is inflammation, the iris may attach to some posterior structure, which is the anterior part of the lens. So the iris's attachment to anterior lens is called posterior synechia. And we can see that from this picture, we put some drops of mydriatic medication so that the pupil will dilate. But here, the dilation is not uniform because of these posterior synechia here and here. But in the lower and upper part of the iris, those parts dilated well, but the nasal and temporal parts did not dilate well because of these synechia posteriorly. In this case, there is another additional pathology in uveitis. The inflammatory cells are accumulating in the anterior chamber. If they accumulate, if they stay there long enough, they accumulate in the back of the cornea, which causes keratic precipitates, which are seen here like little white dots. And if the inflammatory cells are much enough, you can see that they accumulate in the anterior chamber downwards and causes a hypopyon. So this is another entity. Now we know a couple of diseases which may cause red eye. Now let's have a look if we can make a differential diagnosis of red eye. You can see an algorithm here that I did for the purpose of this lesson. And you can always change this algorithm to another one, which you may find easier for you to make a differential diagnosis. I would like to check the corneal staining, the problem with the corneal epithelium first. If there is corneal staining, if there is a problem with the epithelium, I can directly go to a corneal pathology. For example, if there is corneal defect, there is a corneal staining present, it may be bacterial keratitis depending on the discharge, depending on the opacity on the cornea, or depending on the staining on the cornea. If the staining is circular, it's more likely that it is a bacterial keratitis. But if the staining is a dendritic type, then it means that it may be because of a viral keratitis, specifically herpetic keratitis. Of course, in herpetic keratitis, in viral keratitis, the discharge will not be purulent, but the discharge would be more serous or mucous. And if there is none of these corneal infiltrates, but there is an abrasion, it may be a foreign body or an abrasion or an iatrogenic abrasion from a foreign body. If the corneal staining is absent, I would look at the additional pathology on the eye, such as if there are no pathologies in the cornea, in the iris, in the anterior chamber, and there is no staining in the cornea, so the cornea is clear, there is no additional pathology, then I'll just look at the discharge. If there is purulent discharge, it means bacterial conjunctivitis. If there are follicles and the discharge is serous, then it may be viral conjunctivitis. If there are papillary reaction and the discharge is serous and there is itching instead of pain and staining, then it may be an allergic reaction. If there is no discharge and pain, it may be a spectrum of episcleritis and scleritis. If there is an evident pathology, then I can definitely diagnose that patient according to that additional pathology. If the pupils are semi-dilated and there is corneal edema and the intraocular pressure is very high, very elevated, then it's obvious that it can be an acute angle closure glaucoma. If the pupil is small, it's uneven, and when you dilate, it's not uniform, and there are ciliary injection, chaotic precipitates, and there's hypopyon, then you can just presume that it's uveitis. Now, this is the last slide of all. We're gonna have a look at 5 or 6 different pictures and figure out which one is which. So let's have a look at this one. This patient has decreased visual acuity. This patient has pain. This patient has purulent discharge. This patient doesn't have any reaction, but if it had, it would be papillary reaction. And there is an additional pathology here. You see that there is an hypopyon here. So these important findings doesn't actually meet any of our previously learned diseases. So this slide is very important because this slide depicts that if you don't know enough, if you don't have enough information and you don't know enough diseases that may cause that symptom, your diagnosis, your differential diagnosis will be incomplete and most often will be wrong. Because this patient does have another disease that I haven't mentioned before for the purpose of this lesson. And let's have a look at the history of this patient. When you ask this patient what happened, he or she is going to tell you that he had a surgery, an intraocular surgery, 2 days prior to this symptom, which means that this patient has endophthalmitis, the infection of the intraocular tissues. So red eye with hypopyon may be uveitis, but it may also be endophthalmitis, depending on the other structural findings. Here you can see that there is an epithelial problem, so there's corneal staining, there's a pathology in the cornea, and that staining is very specific. The staining is dendritic type, which means that this patient has herpetic keratitis. Here we can see something, again, in a patient with red eye. The visual acuity is diminished. There is pain and burning. There is purulent discharge. There is papillary reaction, and there is an additional pathology other than red eye. You can see that it is here a white opaque plaque on the cornea. And if we ever put some staining on this, fluorescein stain on this eye and check it with blue dye, we would see that fluorescein would accumulate on top of this part, which is the infiltration. And the most likely diagnosis in this patient is bacterial keratitis. Of course, we need to go into detail, and you already have a cornea diseases and conjunctival diseases classes, and you'll find additional and detailed information about keratitis and all other diseases in the appropriate classes. And this picture is here because, not because it has red eye, but because it shows that the pathologies around the bulbus oculi, around the eye, may also cause red eye. In this case, it's acute dacryocystitis, but it may be myositis or orbital inflammation or some dacryoadenitis. Any inflammation in the ocular adnexa may cause red eye. And this is the last patient. This is another red eye with hypopyon. So we already know that uveitis may cause red eye with hypopyon, and endophthalmitis may also cause red eye with hypopyon. There is a third party which may cause red eye with hypopyon, and that is keratitis. There is a subtle infiltration in the cornea here with hypopyon, which depicts that This patient may have keratitis. Thank you. This is the end of the slides. You can reach me from my email whenever you want. I wish you the very best. Thank you.